Hey guys, I wanted to take just a few minutes today to talk to you about what's going on in an ACLS megacode and exactly what the guideline really says. There's a lot of confusion on this, particularly for people that do hard code. So what I want to do is I want to give you a scenario. Let's say you're walking down the hall, feeling good today, you had lunch, and you're doing what all healthcare providers do, glancing in patient rooms. And you see some guy laying there, face up, and so the question is, how are we going to manage this patient? I'm going to start drawing you down a pathway, okay? We find a guy. Hey, are you okay? If there's no response, you already know you need help. So we call our code. We come back and we check a pulse and respirations for no more than 10 seconds. In our case, there's not going to be any meaningful respiratory effort. There's no pulse. So we have identified the need for starting high-quality CPR, and we initiate that as soon as possible. Code team rushes in. Basically, they hook the patient up onto a cardiac monitor. Our first and absolute priority is to find out if this is a shockable event. Okay, so as soon as something comes that could potentially shock the patient, this is our top priority. Nothing else is going to take any precedence over this. We're going to hook the patient up to a monitor. Now, in this case, if you hook a patient up to a cardiac monitor, or monitor defib. All right. Obviously, ventricular fibrillation. Obviously, our first goal is to shock this patient. But you're not going to be able to see the underlying rhythm while somebody's doing CPR. All you're going to see is CPR artifact, literally somebody pushing up and down on the chest. So how are we going to look at the underlying rhythm? Obviously, we need to stop doing CPR to see what's going on underneath it. I would argue here, go ahead and switch your CPR guy. Somebody's going to be off the chest for 3 or 4 seconds while you're switching your CPR guy. Then you take a look at your underlying rhythm. Okay? New CPR guy on the chest because we want to be doing CPR while we're charging. So I got a brand new CPR guy. He's on the chest, charging. CPR guy clear, shock delivered. Same guy can get back on the chest. He's fresh. I just switched him. So we're going to shock the patient. And I want to go ahead and give him a medical diagnosis. Shock number 1. Medical diagnosis, let's say he's in ventricular VFib arrest, right? So shock number 1 for his medical diagnosis of VFib arrest. Followed by 2 minutes of uninterrupted high-quality CPR. Let's examine this terminology, okay? Uninterrupted high-quality CPR. So what's my priority? Always be checking CPR quality. AHA says, guidelines say, studies show us, this is our patient's best shot at survival. Now, if my CPR guy, if his quality's poor, I want to talk him up. Come on, man, you're doing great, you know, hard and fast, make sure you're allowing complete chest recoil, you only got 30 seconds to go. You know, anybody can do anything for 30 more seconds. Talk the guy up before you switch him out, because we want uninterrupted high-quality CPR. Always monitoring CPR quality is our priority. Uninterrupted. That means I cannot put an ET tube in here. Okay? ET tube has not been shown to increase our survival rates. I don't want to stop CPR for 10, 12, 15 seconds. Difficult intubation, a minute, so that somebody can take a look in there, directly visualize the vocal cords, and put something in. Now, if you want to place LMA or some other type of a blindly inserted advanced airway here, that's fine. Be my guest. You got an advantage that way of end-tidal CO2 capability, so you can monitor CPR quality, and you have a little bit more of a definitive airway. You can do continuous CPR instead of 30 to 2 that way. But it doesn't matter. It's okay to continue to do 30 to 2. Uninterrupted, high-quality CPR. Get an IV. If you don't have one, you're always going to be BLS. Come back around. 2 minutes is up. Switch your CPR guy. Here's your opportunity to look at the rhythm. If you have a chance to shock this patient, you're going to. And you're going to shock this patient every possible chance you get. Why? Because it's fun, or however you want to remember it, okay? So, come back around. Rhythm check. What's our rhythm? In our case, our patient's going to continue to be in ventricular fibrillation. Now notice, no drug was given here. This first time out, absolutely no drug was given here. We're going to talk about why. No drug was indicated for this initial diagnosis of VFib arrest. Shock is indicated, followed by 2 minutes of uninterrupted high-quality CPR. I don't even look again at the monitor until I come back around for 2 minutes and I switch my CPR guy. In our case, he's still in arrest, right? So What am I going to do? Shock him again. Why? Because I can. I'm going to give him shock number 2. Let's give him a new diagnosis. Well, I shocked him once, it didn't work. He's in, let's say, shock-resistant arrest. Shock-resistant arrest. So I give him shock number 2, followed by 2 minutes of high-quality CPR. All right? But now I want a drug. I shocked him once, I didn't give him a drug, and now I want one. What am I going to give him? I'm going to give him a vasopressor, epinephrine. An anti-epi. Now, vasopressors are very powerful, very aggressive drugs. And as you watch here, I'm making a spiral, and as I spiral out, I'm becoming progressively more aggressive. All right? Epi is a very aggressive thing to do. And vasopressors have alpha and beta properties. Alpha properties, this is your little blood vessel end on. Take peripheral blood, shunt it to the core. I can see an advantage in a code. Okay, he's got no blood pressure right now. Let's put some in central circulation. They also have beta properties. And the beta properties of vasopressors work directly on the heart. Okay? 1, they have a positive chronotropic effect. Chronos, time, beat faster. He's going a mile a minute right now in fib. All right? Maybe if he goes 2 miles a minute, I can work into a coordinated something. They also have a positive inotropic effect. Inotropy. Squeeze harder. Well, it's not very forceful contractions, okay? Just a lot of fireworks in here. It's a stretch, but I'll buy how the beta properties help in a code. The alpha properties I can see the value of. Now look, this is a very aggressive thing to do. There's a reason I didn't give a drug the first time out. Studies showed this is this patient's best shot at neurally intact survival, neurologically intact. The more epi a patient receives during a code, the worse the overall neurological outcome. All right? There's a reason I didn't give it the first time out. This is very important, and I'm not sure that Heart Code does a really good job of explaining this. A lot of AHA videos tell you to go ahead and prep epi here, but don't give it. And I think that students get very confused with that, okay? Now I'm thinking ahead. I want you to think in the moment, all right? First time out, shock, no drug, very important, no ET tube. Second time, shock. And if you want to stop CPR and put an ET tube in here, that's reasonable, that's fine. Okay? We talked about the advantages of that. 2 minutes uninterrupted high quality CPR. Come back around, switch your CPR guy, take those 3 or 4 seconds to look at your rhythm, still in VFib. What do we want to do? Shock the patient. All right, so we're going to give him shock number 3 here. Let's give him a new diagnosis now just for fun. ICD-10, you know. He's in vasopressor resistant arrest. I gave him a vasopressor 2 minutes ago. Didn't work. Vasopressor resistance. So now I want a different drug of a different class, all right? I gave him epi 2 minutes ago. Let's give him some amiodarone, 300 milligrams IV push. Now this is a very aggressive thing to do, all right? Amio, first of all, IV push, you would never do on a live person because it tanks your blood pressure. Granted, he has no blood pressure right now, but you see that makes me fight an uphill battle. They also cause arrhythmias. Certainly his lethal arrhythmia overrides that concern. Amio, 300 IV push. Now notice, you want these drugs here on the front end, right after the shock, okay? Because you want 2 minutes to fully circulate these things and then see if where they worked. 2 minutes of uninterrupted high quality CPR. Now if you're paying attention here, I gave epi here. 2 minutes later, I gave amio. Could I give another dose of epi here at 3 minutes in? I could, sure. For ease of teaching, bear with me, I'm not going to do that. 2 minutes of uninterrupted high quality CPR, come back around, switch our CPR guy, our patient's still in fib. What do we want to do? Shock him. All right, so we shock him, followed by 2 minutes of uninterrupted high quality CPR, and I want another drug here. Here is where you repeat your amio 150. Okay? And guess what? It's been 4 minutes since my last epi. Go ahead and double down there. That's fine. All right? By the time you're doubling down, this is not going well for the patient. He's had 4 shocks. He's had 2 doses of every drug in the book. It's never too early to start thinking about H's and T's, your reversible causes of arrest. But if you have not started thinking about them, by the time you had your 4th shock, again, you can start up here. By the time you've had your 4th shock and a couple doses of everything, you better start thinking about H's and T's. There is something preventing this patient from coming back. And I get a lot of students, a lot of bright students. Well, you know, I don't know what's wrong with them. I don't have any labs back yet or anything. H's and T's aren't about that at all. It's the obvious thing. It's kind of punishment fits the crime sort of deal, you know. It's you know, this is a 56-year-old guy. I don't know anything else about him. Well, why do 56-year-old guys code? He had an MI. You know, it's the simple thing that you just step back and take a look for. And if you can identify a potential reversible cause, you're going to treat that in a focused way. All right. Another thing comes to mind. You know, you got a 78-year-old man with AV fistula, dialysis patient. Oh, what are we thinking? Well, probably hyperkalemia. And our treatment for that is going to be calcium initially to, you know, strengthen that heartbeat. This is your adult cardiac arrest algorithm. It's this simple. Don't think ahead, think in the moment. You don't have to pre-prep any drug before it's time to give it or anything like that, certainly for the purposes of megacode testing. Right? It's that simple. Shock, no drug. We talked about why that's so important. No drug, no ET tube. Come back around. Shock, epi. Come back around. Shock, amio 300. Come back around. Shock, double down on your drugs. Be thinking about H's and T's. Thank you. I hope to do some more of these videos and see you guys next time. Again, I'm Scott, and I am the co-owner and course director at Carpenter CPR Solutions in Frederick, Maryland. Thanks again.